Hello, everyone. This is Dr. Bishal Gyawali from Queen's University, Kingston, Canada. It's my big pleasure and honor today to be speaking at the Choosing Wisely Africa meeting, and thank you very much for inviting me. I wish I was there in person, but happy to be there virtually. So today I'm going to talk about the financial toxicity of cancer treatment in low and middle income countries. I have no conflicts of interest to disclose. So first, let's define what financial toxicity is. There is no formal definition for this term, but in 2020, we attempted to define this term formally in one of our papers. So we define financial toxicity as the detrimental effects of the excess financial strain caused by the diagnosis of cancer on the well-being of patients, families, and society. So this is a very crucial point. We talk about physical toxicities of cancer treatment, like alopecia, nausea, vomiting, diarrhea, whatever. These physical toxicities affect the patient only the patient. But unlike these physical toxicities, financial toxicity affects not only the patient, but also the families and the society. And that's why it's a serious problem. So what are the causes of financial toxicity? So this can be thought of in terms of, three major buckets. One is the increased expenses after getting diagnosed with cancer. The other is reduced income. And the third is related to health insurance. Some people lose their health insurance after getting diagnosed with cancer, which is very unfortunate. Or some people will have rising cost of health insurance. But the two, so that forms one bucket. The two other major buckets are increased expenses, which is obvious due to the cost of the hospitals and the facilities, diagnostic, surgery, radiotherapy, supportive care. And a major problem is the cost of cancer drugs, which are quite expensive lately, but especially in LMICs, it's also the cost of transportation and lodging and food. And then there is the reduced income part, which is due to, the patient will have to take days away from work. And even if the person is working, there is reduced efficiency at work, and some people might even lose their job. And in LMICs, again, this is aggravated because it's not only the patient, but also caregiver and other members of the family who might have to be away from work. So why are we worried about financial toxicity? What happens if there is financial toxicity? The consequences of financial toxicity. So this is an important point to understand, because when we talk about financial toxicity, some people assume that it's a philosophical or a political thing and not a medical problem. But in fact, it is a medical problem. It is a health issue, because data have shown us that financial toxicity is directly correlated with survival. Patients who have financial toxicity have poorer survival. Patients with financial toxicity have poorer quality of life. So these are medical issues. They are at increased risk of bankruptcy. They have low satisfaction with care. Patients with financial toxicity, they change their prescription drug patterns. They sometimes delay medical care. They sometimes even abandon medical care due to these issues. So this is not just an abstract philosophical or political issue. This is a real medical problem that we should be aware of. So what can we do about it? That's the question. So first, when we have thought about these determinants of financial toxicity, what causes financial toxicity, and then we know about the effects of financial toxicity. Now, the issue is to communicate these problems well and to brainstorm the solutions. And these solutions can be thought of at different levels. There are things that we can do at physician-patient level. There are things that we can do at hospital level, at society level, like institutional societies like ASCO, ESMO level. And then there are things that can be done nationally and internationally. So let's talk about financial toxicity in LMICs in particular. So as we discussed, there are three main reasons for financial toxicity, all of which get more pronounced in case of low and middle income countries. So I'll share some of the studies that show these effects. So this is a study from India in which they looked at financial burden faced by families due to out-of-pocket expenditure during the treatment of their children with cancer. And we'll see something unique in these studies that we do not see in financial toxicity studies from high-income countries. In high-income countries, it's mostly about the drug cost and being away from work. But here you can see that travel expenses constitute a significant burden. Accommodation constitutes a significant burden, and food. Why is it so? Because in LMICs, we don't have cancer centers everywhere. We have cancer centers at certain major urban areas, and patients have to travel a significant distance to reach the cancer center from rural parts of the country. And that is a substantial number of days away from work, also cost related to transportation. And because they are traveling from a different place, they also need to find a place to stay, and they have to eat outside. And it's not just one person because they have to travel. They usually come with a caregiver, so this burden is huge. This study tried to segregate the expenses, and here you can see that the actual medical expenses constitute less than half of the expenditure. It's only 46%. It's more than 50% of the expenditure is related to food, travel, accommodation, and so on. Here is one example from Haiti. In Haiti, medical median out-of-pocket non-medical cost, that is for food, lodging, transportation, childcare, etc., was $233 US dollars for diagnostic visits, $259 US dollars for chemo, and $30 for surgery. The total median out-of-pocket expense was $717. Just to put this in perspective, 3/4 of people in Haiti, they earn less than $2 a day. Less than $2 a day. That's their income. And median out-of-pocket expense for breast cancer patients in Haiti is $717. This is astonishing. What they tell us in this paper is that even if the treatment is free, out-of-pocket cost could account for more than 91% of annual earnings. So as I mentioned, the non-medical costs are so substantial. So even if the treatment is free, the out-of-pocket cost will take away 91% of annual earnings. So again, back to that question, what can we do about it? In this paper, we discuss 4-step measures to addressing this problem. First is acknowledgement of the problem. As we discussed, we should acknowledge that this is a real health problem. It's not a philosophical problem or a political issue. Second, we need to measure it, because if you can't measure something, you can't address it. Third is proper communication, and fourth is thinking about solution at different steps. So let's talk about measuring financial toxicity. How do we measure financial toxicity then? The first formal tool that was developed to measure financial toxicity is called the COST tool. COST stands for Comprehensive Scope of Financial Toxicity. This was developed in the United States in Chicago, and it is based on a questionnaire. And this is what the questionnaire looks like. They have 11 different items here, and the COST score will range from 0 to 4 for each items, and lower the score, lesser is the financial toxicity. So this is how they measured financial toxicity in United States when they developed the COST tool. But what about outside of United States? When I was working in Japan, I worked with some Japanese colleagues to translate this COST tool into Japanese and use it to measure financial toxicity in Japanese patients with cancer. And we found that using this tool, we found that substantial percentage of Japanese patients do suffer from meaningful financial toxicity. Although, unlike US, Japan has a public health insurance system, we still have substantial number of patients who suffer from financial toxicity in Japan. What about other countries? How are they measuring it? In this study from Italy, they used clinical trial data, and in one of the quality of life questionnaire, they asked, what is the financial burden? The answer is in 4 categories, from not at all to very much. And if that answer worsens over time, they define it as financial toxicity. And they showed that financial toxicity was associated with poorer survival. There was a systematic review published in Annals of Oncology about methods for measuring financial toxicity. And their systematic review found that there were several different ways to measure financial toxicity, but they included objective financial burden and subjective financial distress. And they also found that people were using the terms very loosely and differently. Someone was saying financial burden, someone was saying it is financial catastrophe, financial difficulty, financial distress, hardship, and so on. So there is no uniformity in how people are defining this. But one important thing is, I think we should not think that the same tool can be used to measure financial toxicity everywhere in the world. And in fact, there was a very interesting letter to editor published by the Italian group, in which they argue that we should move away from a one-size-fits-all approach, because every country's, every health system situation is different. So a financial toxicity tool to measure financial toxicity in that particular setting should take that into account, which makes perfect sense to me. For example, in this study of financial toxicity from India among patients with pancreatic cancer, they mention in the methods that they tried, they talk about this cost tool that I previously mentioned, which is validated in United States. And they tell that because that tool was published after they planned the study, they could not use this tool. But what I would argue is, even if this cost study was published later or earlier, before the study commenced, I don't think it was appropriate to use cost tool to measure financial toxicity in India, because the situation is completely different. There should be a tool that is tailored to the local context. So in this study, what they did, how they defined financial toxicity, was they called more than 10 out-of-pocket cost of more than 10% of total annual household income as catastrophic financial burden. They use the term catastrophic financial burden, and they say that if more than 10% of the total annual household income is spent in out-of-pocket cost for cancer treatment, that is catastrophic financial burden. What about some data from Africa? I found this study from Nigeria among breast cancer patients, where they looked at out-of-pocket cost, and they found that 68% of the breast cancer patients in Nigeria had no health insurance. And based on a household's capacity to pay, 90% of the patients would experience a catastrophic health expenditure. It's good to get such data from LMICs, but this study included only 22 patients. So you can't make much conclusions from 22 patients. We need more richer data coming from Africa to inform this dialogue. And I found a paper from Tunisia, in which they again used the cost tool to measure financial toxicity. This was a richer source of information, because they had 179 participants here, and they found that the median cost score was 20.8, which is similar to what we found in Japan. The median score was 21 there, and they found that almost 12% of the patients had grade 2 financial toxicity, and almost 70% had grade 1 financial toxicity. And the most important factors for financial toxicity was the distance to the hospital and quitting work. These are important findings, but again, I don't think cost tool is the best metric to measure financial toxicity in countries like Tunisia. Cost was made and validated for the US. Another study from Egypt of 100 patients, in which 66% needed financial assistance. These are all patients with breast cancer. 80% had great difficulty in affording medications, and they also found that the employment, many people quit their job after getting a diagnosis of cancer, because 15% of these women had employment after the diagnosis of cancer, compared to 33% of the women who had an employment before the diagnosis of cancer. And half of them had food insecurity, and 1/3 reported difficulty to afford transportation cost. So there are unique challenges in LMICs, and there are unique causes of financial toxicity in LMICs that need to be addressed. So we actually try to do that in Nepal. In Nepal, along with my colleagues, we tried to come up with our own locally tailored definition of financial toxicity. We published this report in Lancet Hematology in 2020. We studied patients, Nepalese patients with acute leukemia in a public hospital. So as you know, acute leukemia treatment is usually with classical old cheap cytotoxic drugs. There are no fancy newer targeted therapies or immunotherapies for acute leukemia. But even when the treatment is so cheap and at a public hospital, we found that a huge number of our patients do suffer financial toxicity. So first, how we define financial toxicity, this is how we defined it. We came up with 3 parameters that are locally tailored, important in the Nepali context. One is selling property, like selling their house or land or livestock to support cancer treatment. Second is borrowing loans at an interest from friends or relatives. They can borrow loans. Third is asking charity from the public. The difference between loan and charity is loan you pay interest, in charity you don't pay interest. You're just asking for free money. And we defined that if out of three, if the patient had to do two, at least two, then it's called severe financial toxicity. If the patient had to do all three, then it's extreme financial toxicity. And this is what we found. We found that 112 patients that we studied, 94% of them, they had to ask money from, they had to ask for charity from the public. 88% of them, they had to borrow loans from friends or relatives. And 87% of them, they had to sell their property, house, land, and livestock to support cancer treatment. 96% of our patients had severe financial toxicity. They had to do two of these. And 73% of our patients had extreme financial toxicity. They had to do all of those. And when they are borrowing loans from friends or relatives, some of them are paying as much as 36% interest. And we found that, most of our patients in this cohort, they were coming from outside of Kathmandu. This hospital is in Kathmandu, but they were coming from outside of Kathmandu. So probably the travel and food cost added a lot. And 31% of them were uneducated. So these type of simple studies also provide us opportunities to think about what can we do for them, simple solutions. Because as I mentioned, some of them are paying such high interest rate. One of the solutions that we propose is that we can offer loans to these patients at a cheap interest rate. And because it is usually a curable condition, they can pay back the loan by undergoing some job or employment after getting treated. And in fact, this is something that has been translated into action. My colleague, Dr. Bishal Gyawali, who is the first author of that paper, he has started a foundation to support patients in this journey by offering them loans at a cheap rate upfront so that they can undergo treatment and then they will pay it back later. He's collaborating with a bank to do this. The other solution that comes up from this study is that we need to build cancer centers in other parts of the country. We have several cancer centers in a couple of urban areas, but there are no cancer centers in other parts of the country. So patients are traveling almost 48 hours one way sometimes to reach the cancer center, and that is adding to the financial toxicity for them. These are the type of solutions that we can think of when we run such a study. Although it's a simple descriptive study, it is helpful in that way. And then we need to think about protection for the caregivers who sold their property to pay for cancer treatment for a family member. As I mentioned, a substantial percentage of our patients are selling their house and land to support cancer treatment. And what happens to the people who are left behind, the other members of the family, if the patient dies, now they don't have their family member and they also don't have their property. This also speaks for the need of a national health insurance system. And in fact, in 2016, Nepal did launch a pilot health insurance program in 3 districts, which has now expanded to cover almost 78% of all the districts in the country. And once it reaches 100% coverage, it might help mitigate this problem to some extent. And then there is the question of public-private partnerships to achieve universal health coverage. So measuring financial toxicity and addressing financial toxicity by doing such type of research is what I think is ground shot type research. You must have heard about cancer ground shot, which I strongly advocate for. In addition to cancer moonshot, we need to have research that are meaningful and applicable for our patients to improve access to treatments. And I think working on financial toxicity, thinking about how to measure it and how to solve this problem is a type of cancer ground shot research. So as I mentioned, it's a 4-step thing. We need to acknowledge the problem, which I think we have all done now. And the second thing is to measure the problem, because if you can't measure it, you can't solve it. So I think for LMICs, we are still stuck in that part. We haven't been able to measure the burden very well. So we need more and more research in that. And then we need to communicate that problem well and think about solutions. Now, what can we do about it? And as I discussed through our Nepal study, the measurement and the solution piece and the communication piece, they are closely aligned. It does not have to be three discrete steps. You measure it, and in the process of measuring it, in the process of researching it, you can come up with those strategies based on what is causing financial toxicity and what we need to do about it. So in conclusion, financial toxicity is probably the most important barrier for cancer care in LMICs. You cannot know what you cannot measure, and you cannot solve what you do not know. So we have to measure it as the first step. Then only we can understand it well. And once we understand it well, we can solve it. We all have a role in addressing this problem. As physicians, as patients, as members of the community, as stakeholders, as politicians, we all have a role. And this problem is solvable because unlike cancer, financial toxicity is a man-made problem and we can solve it. More research to understand financial toxicity in LMICs is needed. And understanding financial toxicity is an example of cancer groundshot type research. Financial toxicity measurement and addressing of this problem, it needs to be tailored on the local socio-economic cultural context. We cannot pick up a tool that was developed for United States and use the same tool to measure financial toxicity in our country and assess financial toxicity based on that tool. We need to have our own locally developed tool. And we always talk about precision medicine, precision oncology. We need precision. Financial toxicity research also needs precision. You cannot use a different tool made for different context and use it for your patients. We need a precise tool for our context. So that approach of precision medicine should extend to financial toxicity research as well. Thank you.